Hello, my name is Jones Muna. Today, we look at anemia in pregnancy. Introduction. Majority of pregnant women in developing countries are grossly anemic. Anemia can cause death of mother directly through heart failure or lead to problems such as abortions, premature labor, and intrauterine death of the fetus, postpartum hemorrhage, or puerperal sepsis. There are many causes of anemia in pregnancy. Anemia developing during pregnancy continues afterwards, and in most cases another pregnancy follows before the woman recovers. The woman therefore suffers from chronic ill health in most of her life. Definition. Anemia is a reduction in the oxygen carrying capacity of the blood. This may be caused by a decrease in red cell production or reduction in hemoglobin content of the blood or a combination of these. Miles 2003. Anemia is a state in which the blood hemoglobin level is below the normal range for the patient's age and sex. Kpo, 2002. Causes of anemia in pregnancy. Anemia in pregnancy is caused by a combination of factors such as 1. Increased demand due to pregnancy. 2. Deficient intake of raw materials such as iron, folic acid, or vitamin B12. 3. Acute or chronic blood loss. 4. Increased red cell distraction. 1. Increased demand due to pregnancy. This is the most common cause of anemia in pregnancy. The fetus takes something like 300 milligrams of iron from the mother. Mother's own expanded blood volume, the placenta, and the growing uterine muscle need a further 700 milligrams. This means that there is usually a negative balance as the normal diet only affords some 3 milligrams of iron daily to the mother, and only 10% of iron in the diet is actually absorbed. Folic acid and vitamin B12 are equally on demand, and if the intake is not increased, deficient will occur. Multiple pregnancy increases the demand on the mother's resources further. 2. Deficient intake. To manufacture normal red blood cells, the body requires protein, iron, folic acid, and vitamin B12. Deficiency can be due to lack of the right food or inadequate food, poor appetite of the pregnant woman, malabsorption due to chronic diarrhea. 3. Acute or chronic blood loss. The woman might start the pregnancy already lacking iron. This might be because of heavy menstrual flows or bleeding in past pregnancies. These past pregnancies, which very often follow each other very closely, might have been complicated by antepartum or postpartum hemorrhage or hemorrhoids, which will cause further loss. Further blood loss might be caused by hook worm infestation. Each worm is capable of extracting up to 0.05 milliliters of blood per day. In heavy infections, the patient could have up to 1,000 worms. You should therefore check the stool of every pregnant woman for hookworm. If you have no laboratory facilities and you are working in an area where hook worm is endemic, you can give 1 dose of Vermox 5 tablets start to deworm each woman in pregnancy. 4. Increased red cell destruction. When red cells grow old, they are destroyed in the spleen and the liver. In some pathological conditions, where red cells have a strange shape, such as in sickle cell disease, this destruction is accelerated and the cells have a shortened life, especially when the oxygen in the blood is low. As pregnancy advances, the large uterus prevents the lungs inflating fully. This leads to lower oxygen concentration in the blood and cell destruction is increased. Infection with falciparum malaria also leads to destruction and hemolysis of the red cells. Folic acid is therefore used to replace the destroyed cells. You should give these women extra folic acid throughout pregnancy and also give malaria prophylaxis. Signs and symptoms. A drop in hemoglobin level deprives the tissues of adequate oxygen. The symptoms of anemia are in fact symptoms of oxygen lack. Kpo, 2002. These include the following: weakness, tiredness, dizziness, breathlessness on exertion, heart palpitation, paresthesia in fingers and toes, headache, apathy, increases heart rate, restlessness, air hunger. On examination, pallor of the skin, mucous membranes, palms of hands and conjunctivae. There may be edema, tachycardia. Examination with stethoscope reveals systolic heart murmurs. Treatment. The management of patients with anemia depends upon the severity of the condition. Regimens will vary according to the prevalence of anemia, the size of your unit and its facilities. If the problem is diagnosed before the 30th week of pregnancy, then most anemia can be improved sufficiently within the remaining 10 weeks so that labor is no longer a danger, as it would be to a very anemic woman. In pregnancy, the blood is always slightly diluted because of the increased fluid volume of the body. Therefore, a pregnant woman's hemoglobin is always about 2 grams per 100 lower than when she is not pregnant. In East Africa, women with hemoglobin estimations below 5 grams per 100 milliliters should be considered anemic and managed as follows. HB above 9 grams, follow up regularly in the antenatal clinic and double the normal dose of folic acid 10 mg per day and the normal dose of ferrous sulfate 600 mg per day. HB below 9 grams but above 7 grams, admit to a hospital where usually a total dose infusion of iron, as Infrin, will be given if the pregnancy is less than 36 weeks and the woman will be discharged on the regimen above. HB below 9 grams in the last 4 weeks of pregnancy. These patients, together with those with an HB below 7 grams at any stage of pregnancy, should be admitted to hospital for blood transfusion followed by a total dose iron infusion. If such a patient is being referred from a rural health center, then relatives willing to donate blood should accompany her. Heart failure is